So without the assistance of our flashing lights here, I'm apparently the world's worst moderator because we were over on time. But we're going to open the floor up for questions now for our committee members, and I think we'll try to have about 15 minutes for questions and answers, and our forum committee members here will be around later to answer additional questions. But if I could just ask those of you who will be working your way to the mics, I hope some of you do, have been waiting to ask questions about the task force, I know. Try to keep your questions distinct so we can get to as many questions as possible. So would anybody like to start us off?
Hi, thank you very much. Kimberly Hogewood, NYU, also Division 53 of APA. This thing's sort of high. I'm used to being here. Question, what we're trying to do in this forum, as I understand it, is to identify ways to improve the dissemination of evidence-based preventive programs. And so my question, I think, is largely to the federal folks, although I think, Alex, you may have a perspective too. And it has to do with, yeah, okay, opinion is fine, that's fine. Is there any repository or collation of failed preventive programs? I find that I learn as much from the failures as I do from the successes, and so it's great to hear about those that are working, but what about those that don't work and why?
I think that's a very good point. We're working on a manuscript right now, for example, on an intervention that's delivered by physicians to their HIV positive patients, and it's a 7-minute intervention. And we were told by working with clinics, you need to train the whole clinic, bring the whole clinic together, you know. And so we trained social workers and nurses and nurse practitioners and physicians, et cetera. But then after we had trained this intervention multiple times to about 500 clinics in the country, we looked at our data and found out only 2% of the people that were in the training were physicians. We were training receptionists, we were training secretaries, we were training laboratory people, and only 2% of the people in the training room were physicians. And then when we started looking at going back and doing interviews, we found only 50% of the physicians that we trained were delivering the intervention. You know, and so I think my point of it is I think negative findings are very important, and they're very important for being able to change direction and determine how you might in fact work in a different way. In this case, we've decided that this intervention, which takes, you have to close down a clinic and train everybody for 4 hours, and we said this is not going to work. And so we need to find a way that physicians can get continuing medical education. They can learn this intervention online, and they can learn it in 15 minutes, you know. And so let's use new technology, let's target the training, let's find a way to deal with the incentives, so in fact we can improve on the fact that we've been unsuccessful. It didn't work. Let's find a way to make it work.
Alex, all three really very helpful presentations. Alex, I had two questions for you. One, if we could, I don't know if we could possibly see Alex's slide 13. Is that possible? The last presenter's slide 13, I think it was. No, it was the one that showed the screening, et cetera, for alcohol. Maybe not. Oh, I'm sorry. I thought it was 13. Go one more. One more. That one. The question I have is about screening versus counseling. Specifically, this one shows the importance of screening if you already have alcohol misuse. But you talked about for tobacco, it's a counseling intervention that could be trying to prevent the incidence or the initiation of tobacco use as something that has a B rating. Could you talk to us about what you're looking for in those situations where it's not so much a screening question, or at least it didn't seem like that one was approved based on screening, but more on the intervention itself being seen as something that was worthwhile doing, perhaps to all? I wasn't sure whether it be to all or not.
Great question. I'm sorry, gotta turn me on. So I can pull up a counseling analytic framework, but it really falls along the same questions in terms of you know, what are the harms of providing the counseling, and does the counseling lead to the intended outcome? So, for example, decreasing initiation of tobacco use. And I have to go back and look at that particular one, but they're probably, I'm guessing, because they all have them, both intermediate outcomes and final outcomes. So an intermediate outcome might be some sort of proxy estimate, of tobacco use versus actually, using tobacco and those kinds of things. But the same sort of questions would go all along. And, so this predates me, but there would be the overarching questions. So first looking at whether or not there were any examples of randomized trials of counseling. My guess is that there probably weren't. And so then you have to go through that pathway of looking at the linkages within there. But conceptually, it's the same process where you have to look at sort of each step along the way.
And my second question is just, at some point, if there's time, could you talk to us about Bright Futures?
I'd be happy to talk about Bright Futures. And so first, I guess my disclosure is that I work with the Bright Futures folk in terms of doing their evidence review. So Bright Futures is different. Bright Futures is a project funded by HRSA. Right now it goes through the American Academy of Pediatrics, has gone through other groups before. And Bright Futures makes recommendations about the kind of care that children ought to get as part of preventive services. They have like a great big book that tells you everything that ought to happen. They also have toolkits about how to put things in. And then related to this, they have what's called the periodicity schedule. The periodicity schedule is kind of like, these are things that you really ought to do. And has little, bullet points for the ages where you do it. But Bright Futures really goes beyond that in terms of recommending a lot of behavioral counseling and intervention, stuff like that the task force doesn't address. They have different methods. They also have different purposes. I can tell you anecdotally that pediatricians really do value Bright Futures and look to it for a lot of work that they do. I also know that historically Bright Futures hasn't been as evidence grounded as other groups, and right now, especially because of the attention being paid to it because of the Affordable Care Act, they're trying to raise the level, raise the process. But the reality is, for a lot of the care that we provide to children, the evidence just isn't there. And so this really provides a different roadmap for pediatricians, given the lack of evidence that's out there.
Thank you. Mary Jane?
I also have two questions. First, thank you. All the presentations were again great. So, Fran and Charles, both SAMHSA and CDC are involved. They've certified this whole set of interventions, and both of you talked to the importance of adaptation and what's going to happen in communities, and the renewed importance of both of your agencies in healthcare, whether that's HIV or substance use in primary care. In medicine, there's always been an approach for iterative quality improvement. Given that you're both out there funding these agencies on an ongoing basis, do you have ideas, what should the data system look like that's going to inform iterative quality improvement for prevention programs, for this adaptation of evidence-based interventions in the future?
Well, I would hope that we would be able to begin to capture the health status and the success of changing in a particular community that's very much at high risk of diabetes, and show that the types of programs that we fund using the evidence-based practices that we have, if we're able to help bridge that gap and help our workers understand how to work with their health partners, we should then begin to see a decrease automatically, even without changing much of the health regimen. So that's one of the hopeful processes that we have to show that our field does not have to morph into anything. It just needs to find that connection to health and how to become a real active participant. And the measures would be a combination of both health measures and of the intervention that's done, or the prevention program that's being followed with fidelity on a science, a primary prevention program.
And, we sometimes use the term like mid-course correction, and I think one of the things that we've tried to stress is that no, mid-course correction is probably, you're already lost. And so, in fact, you really need to start thinking a little bit about which of your interventions are being selected and which ones are not, and figure out why the ones that are not being selected are not being selected. You also have to think about your training data and find out, do people actually leave the training with the skills, with the materials to actually implement the intervention? If not, you need to make a correction at that point. You also have to start thinking about implementation and looking at reach for the program. How many people are they seeing with this program? Why are they not seeing more people with this program? And if you see across a program there's not much reach, that may be an intervention you may think needs to be discontinued. Even though it may be evidence-based, it may need to be discontinued if you can't get people into and retain them into the intervention. And then you look at your outcome monitoring to see what kind of outcomes are various programs around the country getting, and actually let them serve as each other's control group, so to speak. So you're looking at 10 programs that are all doing outcome monitoring for this intervention. Let's see what kind of outcome variance are we getting, and let's try to see are there any implementation clues as to why one program is getting better outcomes than another program. So I think you have to think about that whole process step by step, in terms of corrections to your system.
We do cross-site evaluations to mostly get at what you're speaking of. It's the bridge into health that we would need help with. But I have my colleague from mental health who wanted to add. You'll have to go to a...
You have to a microphone, please.
You have to go to a microphone.
I enjoyed your question because it's something we think about a lot in prevention practices and schools grant. And from the very beginning, we've had an alliance with 3 of the experts in the good behavior game across the country that have been kind of informally advising us directly. And we talk about adaptation issues. So we've been working with them as we go along. I think it's a great collaboration. And also in our work with CPIM, I think it's a great question for us to talk together about a potential research question that we can work together to try to solve.
That's great. I have one other question, and it's really directed at Alex. So I saw that any of the issues that you've brought up is a big impact, negative, severe outcome. If we took, though, like asthma or a whole range of health outcomes, there would be evidence that parenting classes influence 5 different outcomes. And I would bet it's going to come up an A and a B, but parenting wouldn't be up there on the list. How do you see either Bright Futures or the U.S. Prevention Task Force, Public Health Task, whatever it is you sit on, how are we going to get something like parenting to be linked to outcomes, because there's huge data around both monitoring, or whether it was coercive discipline or catching your child being good, that parenting skills are related to these really high-cost negative outcomes, and things like adherence for a whole range of diseases.
So, first, I'm going to wear my general pediatrician hat, which is, I agree with you that parenting classes can be really important for a lot of different outcomes. The issue is the U.S. Preventive Services Task Force I'm channeling the task force, so this would be a sort of a task force related question in general, and so I hesitate to answer for a large group of people. But the kind of issues would be whether or not counseling for all families to go to parenting classes, right? So the task force deals with primary prevention, so patients without any signs or symptoms, whether or not they should go to parenting classes for whatever particular outcome, all right? But the task force is not the only game in town in terms of looking at recommendations for pediatricians or for family docs or nurses and so forth. I don't mean to single out in a particular group. There's the community guide, right, which makes recommendations for community level interventions for children run out of the CDC. the American Academy of Pediatrics is very active in making recommendations that pediatricians and family physicians also follow. And certainly that's a topic that Bright Futures could conceivably address. But if you're in particular thinking about the role of the U.S. Preventive Services Task Force in terms of recommending parent classes, right? It's the task force is really interested in primary prevention of targeted conditions. So, for example, if you wanted to decrease asthma-related morbidity through parenting classes, through counseling that all children ought to get referred. It just doesn't fit in there exactly, right? Because you're only going to, for asthma, you would only refer families who have a child with asthma, right? So you just have to think about, does this fit into the primary prevention paradigm, or is this really secondary or tertiary prevention? If it's those latter things, it's really not for the task force, but it would be for the community guide or for perhaps Bright Futures.
Thank you. So we have only a few minutes left, and I'm sensitive that we have 3 individuals who want to ask a question. So I'll turn to the center aisle, and please have a short question.
Again, thanks for 3 very stimulating presentations. I particularly liked your comment that to make adaptation your friend, Charles. I thought that was great. But I have 2, actually, I'm going to say 1 two-parter, or 2 linked very short questions for Alex and Francis. The first question is, where on your list of evidence for or against is assessment for maltreatment and, more broadly, treatment for maltreatment? Has that been looked at by your group, Alex, or?
Yeah. So I just want to caution, it's not my group. Because now as I sit in DC, I don't want to get in trouble. But so treatment per se is not something that the U.S. Preventive Services Task Force would look at. They would look at treatment in the context of whether or not, for example, all children ought to be screened for child maltreatment, which I could be wrong, but I don't think the task force has ever looked at in particular. I'll tell you that the Bright Futures has recommendations about the kinds of things that ought to be looked at, and certainly the Academy does and other people do, but that, as far as I'm aware, has not been something that's been looked at by the task force.
Because it's not.
Go ahead, nominate it.
Too complicated, or no?
No, nominate it. I mean, it's just these are issues that are nominated by the public. Now, I just don't know the evidence or how things might play out in terms of the recommendation that all children should be screened for maltreatment. And I can imagine ways of doing it, but that would have to be one of the things versus another way to do it would be to think about counseling parents around maltreatment, or things to reduce stress, the period of purple crying and that kind of thing. I mean, there are different ways to think about doing it. But as far as I'm aware, and I could be wrong, I can look once we're done. The task force hasn't looked particularly at child maltreatment.
Well, that's interesting. And then Francis' question, the SAMHSA-sponsored National Child Traumatic Stress Network subgroup looking at substance abuse is certainly very interested and believes that there are strong links between child maltreatment of all types and substance abuse. Is that a belief that is held or examined or screened for outside of the relatively narrow confines of people who are looking actively at child maltreatment? In other words, when SAMHSA has other projects focused on adolescent substance use, is that something that is taken into consideration, or is that belief, only held by people who are trauma researchers?
No, I think within SAMHSA, we are not looking at that in the prevention realm specifically. However, in mental health, there's a much closer relationship. But what that office does, or committee does, is to work with our other federal partners who do work primarily with, it's not working. Sorry, easily distracted. I'm sorry. It's okay. With our federal partners to work on that, on traumatic adolescents. So I don't know how to answer your question.
Well,
Do we ignore it? No, but is it a natural part of the prevention of mental and substance abuse disorder? I wouldn't say it's a natural funded part, no, but with CDC, ACF, and even ARC in some levels, and Indian Health Services, we're getting a lot of mileage with that. You can only fund so much.
Well, so another question would be, if you're looking at a substance abuse program,
Right.
would you think it was a natural thing, and your group think it would be a natural thing if part of their assessment included screening for trauma?
Yes, it's something we would not kick right out if it's not funded with the block grant dollar. 20% of block grant of the block grant for substance abuse has to go to primary prevention. But we have a discretionary portfolio, and that would be something we would consider from a community or a state.
Thank you.
Great. So I do apologize. I know we have 2 remaining questions, but we're going to have to cut this session short because we've already gone over time. So perhaps you can connect with our panelists afterwards. But please join me in thanking our panelists for a wonderful panel and discussion. I'll turn it over to Mary Jane.
So my job is to say, you get to talk to each other a few more minutes, and then at 5 minutes to 3, back to your work groups. And just to remember that you have 3 guiding questions in these work groups. And I'm going to refer you to the first page of your agenda, but it's really, how have the existing scientific norms, our financing models, and our practices either helped or served as a barrier to broad uptake and diffusion of evidence-based practice? The same question about our financing models, and then what can we do in the future? These 3 questions your work groups need to answer. Thank you, and we'll see you back here at 4:30.